So I'd like to welcome Dr. Sukhjinder Marwah, I hope I've pronounced that correctly, who's going to give us a talk about the COVID-19 induced changes in blood SARS parameters for all ethnic groups. Over to you.
Thank you. Thank you. First of all, I'd like to thank IBMS for inviting me to this symposium to share our data from two general hospitals, which was Sandwell and City Hospital in Birmingham. My key role is actually I'm the lead for the hemoglobin diagnostics, covering both sites and obviously a referral centre to our neighbouring hospital as well. So the aim is obviously when the first pandemic, the laboratory went a bit quiet. So myself and the consultant sat down, we should actually start collecting data on our COVID patients, which are actually on ward or admitted, and see what we can actually extract from the data and present it in one of the papers. So next slide, please. So what I'm going to do is obviously give you a little introduction to the vicinity area of this single centre, and that's based in the southwest Birmingham area, and how the COVID-19 affected the southwest Birmingham area, the method we used for collecting data, how we analysed the results and what the results showed. Sorry, back please. And what were the risk factors that contributed to mortality from that? And then obviously I'll summarise at the end as to what our finding was. Next slide, please. So if you look at the South Birmingham area, the area is 85.6 kilometres, which is a fairly large area, and that covered a lot of little towns like Wednesbury, Tipton, West Bromwich, Rowley Regis, Smethwick. And these two big hospitals are based, one in Smethwick area, and the other one is actually based in West Bromwich. So because this is on the same limb system, we will actually able to collect the data. Now the graph on the map on the right hand side just show the intensity of the population of the ethnics. So the deeper, the stronger the colour, the stronger is the population in those areas. So as we can see, the minority population do actually concentrate in certain pocket areas rather than spreading all over. Next slide, please. Oh, that's great. Thank you. So if you look at the Sandwell population, okay, and out of the population, we actually broken down into different ethnicities. 57.2 are white, and then the big chunk, and the next one is the 25.8 Asians. Then you have just under 9% black, then mixed population, and others as well, who have no defined ethnicity. So overall, about 43% population of Sandwell is actually ethnic minority. Next slide, please. And if you look at the Sandwell area itself, it's probably the most deprived area in the whole UK. And if you first of all look at Birmingham, Birmingham obviously is again it's the most deprived area. And within Birmingham, you can look at Sandwell further down, and Sandwell sort of equates very similar to the Birmingham area. And if you want to parallel to Sandwell area, that's sort of parallel to Stoke-on-Trent, Walsall, and Wolverhampton. So these are the areas which are mostly deprived areas living with a higher ethnic minority population. Next slide, please. In the 2015 census, West Birmingham had a higher proportion of its population living in the most deprived quintile, 29% compared to the rest of England, just 20%. And Birmingham has the highest proportion of its population living in most of the most deprived neighbourhood. And the neighbourhood actually is where these two hospitals actually are based. And in Birmingham, 54 to 57% population are resident in area which is mostly deprived quintile. And that includes Sandwell, like I said, and that's comparable to Stoke-on-Trent, Walsall and Wolverhampton. And if you go one step further, look at the housing occupants, what you'll find is that the ethnic population tend to live in very small houses, terrace houses, and there seems to be over-occupied. Larger families or multiple families are living in small areas. Next slide, please. And now let's move on to coronavirus. I mean, I'm sure we've heard this a lot, so I'm not going to dwell into much of it. So just as you can see, the size is fairly small, 65 to 125 nanometers in diameter. It's a very small virus. Corona basically represents the cone-like spikes on the outer surface of the virus. Thus, it has named as the coronavirus. Contains a single strand RNA as a nucleus material. Size ranging from 26 to 32 kilobytes in length. Next slide, please. So there were two previous outbreaks due to coronaviruses. One was SARS, 2002 to 2023 in Asia, where 8,469 cases with 800 deaths. The next one was MERS, between 2012 and 2023 in Saudi Arabia, with 27 other countries, 2,603 cases with 854 deaths. And this most likely ecological survivor for coronavirus are bats. It is believed that the virus jumped the species barrier to human from another intermediate human host. Next slide, please. So again, I mean, I'm sure this was dealt earlier. Even Andrew mentioned it, originated from Wuhan, okay, in China, and zoonotic origin by March 2023. 676 million cases were confirmed, 6.88 million deaths has taken place, and this virus has spread over 197 countries or territories. Way of contagious, as we all know, it droplets of particle from nose or mouth, which are spread, and when a person coughs or exhales, these droplets land on objects and surface around the person. Next slide, please. Symptoms, I'm sure we all know this again. I'm not going to dwell much into this. So we have obviously two forms to a distinct situation. Non-serious presentation, with outpatient settings, and B, requiring hospitalization. Symptom like pneumonia, respiratory failure, and that's the acute respiratory stress syndrome, and most likely the serious complications. Next slide, please. So we had this idea. We knew our hospital actually were full of patients with coronavirus, and we had patients queuing up in the corridors. Even the ambulance were actually waiting aside. So we actually had a hypothesis. So we designed the hypothesis. What we're going to look at. We said what we'll do. We'll collect the data. We will look at both hematology and biochemistry data in both Caucasian and combined group of Black, Asian, and minority ethnic BAME groups. Tested who were tested positive and who died compared to survivors. And the next biggest hurdle we had was getting the ethical approval for this project. It took us nearly 9 months to get the full approval. Finally, it was granted, and we were able to go ahead and collect the data. Next slide, please. So this was actually a retrospective cohort study, and the data was retrieved from the hospital LIMS system, and the patient were identified as COVID positive by reverse transcriptase polymerase chain reaction from the throat nose swab on a Roche Cobas analyzer. Full body counts were actually analyzed on Sysmex XN automated hematology analyzer. The coagulation studies were done on the instrumentation laboratory ACL 350 and 550 analyzers for PT, INR, PTT, and D-dimers. And then all the biochemistry analyses were performed on the Abbott Architect analyzers. And then when we use various statistical analyses to perform to look at the data and to give us the mean or the medium values. Now, just to emphasize the point that this collection of data does not actually collect all the data. Those patients who were dead on arrival to A&E was not included, and those patients who died in A&E but not admitted to the hospital, those were again not included in this data collection study. Next slide, please. So this data in the first pandemic was collected from the 3rd of February to the 4th of September 2020, and that included 445 patients over the age of 18, 252 males, and 193 were females. Out of those, 46 were admitted to ICU, and 70% of those patients were from the BAME group. So you can see the significant rise of ITU admission from the BAME group. And patients survived, equivalent to 255, and there were 132 Caucasian and 123 from the BAME group. So there we are. There's a table showing that the patient survived and died from the BAME group. Next slide, please. So after 28 weeks of collecting data, 190 patients, 42% had died within 28 days of COVID diagnosis being positive. 97 of those were Caucasian, which equates to about 42%, and 93 were BAME. Using the general linear model analysis, found that the ethnicity interaction with mortality to be significant for fibrinogen, ferritin, and A1C after controlling for age. So obviously ethnicity played important role in the mortality of these patients. Next slide, please. So this first graph is showing the clinical observation finding of all patients on admissions. So first of all, what we found was that the graph, the table on the left-hand side is from Caucasian. Okay, the survivors Caucasian were younger compared to the fatality Caucasian. There was significant difference there. Then if you move to the BAME group, the table the right-hand side, again we saw the survivors in the BAME group were younger compared to fatality groups in the BAME group as well. So, and the overall there was significant difference between all these groups. And next one, which is presenting in numbers. And the next biggest significant difference we found were the diabetes. In Caucasian group, we did not find any significant difference whether the patient were diabetic or not non-diabetic. However, when we looked at the diabetes in the BAME group, well, then what we found that in survivors and fatality, there was a significant difference. And so fatality group, there were more diabetic patients there, 68% compared to the survivors in the BAME group. And then obviously we looked at the other parameters like the breathing rate, heart rate, oxygen saturation, and hypertension as well, but we did not find any significant difference there. Next slide, please. So the finding summary from the first table in the is in both groups, the youngest will survive compared with those who died. Okay. And in this study example, diabetics was also linked to Caucasian, was not linked to Caucasian deaths but was strongly linked to the BAME group deaths. So diabetic had a big influence on the fatality of these patients in the BAME group. Next slide, please. So this is the hematological now. We obviously look at all the different parameters of the hematology or full blood count analyzers, that including the hemoglobin, obviously MCV, neutrophil, lymphocytes, PTT, D-dimers, fibrinogen, ferritin, and A1C. So the figures in red, that's where we actually saw a significant difference. So first of all, in the Caucasian group, what we found, the MCV was lower in the survivors compared with the fatalities, whereas we found no difference in the MCV in the BAME group at all. The neutrophil ratio, so the neutrophil count greater than 7.5, again, we found no difference in the Caucasian, but this time we found a significant difference between the BAME group survival and the BAME group death group fatalities. Lymphocyte ratio, or lymphocyte less than 0, less than 1. Again, we found there's a big difference between the Caucasian survivors and fatalities. And then similarly, we found lymphocyte count less than 1 big difference, significant difference between the survivors and the fatalities in the BAME group. There was significant difference there. Then we didn't find any significant difference in the PTT, D-dimers, fibrinogen, and ferritin until we came to diabetes A1C level. And then well, that's why we found that in the Caucasian group, there was no difference in the survivors and fatalities with A1C, whereas we found in the BAME group, there was a significant difference in the A1C level between survivors and the fatalities. So in fatalities, we found there were higher proportion of diabetic patients who actually died. Next slide, please. So this table 2 summarized fibrinogen was significantly higher in the Black fatalities group compared with Asian fatalities. The general linear model analysis data not presented found that the mortality and ethnicity factors interaction to be significant for fibrinogen, with a significant effect of ethnicity on the mortality. Median A1C was significantly different across the group, the BAME group having a higher values, and the GLM analysis adjusted for age found that mortality with ethnicity factor to be significant for A1C. Thus, there was a significant effect of ethnicity on mortality where there was diabetic present. Next slide, please. Now, this is the parameters we looked at from the biochemistry analyzers. So we collected the data. Again, the figures in red, that's where we saw significant difference in the survivors and fatality group, in the Caucasian group, and similarly in the survivors and fatality for the BAME group as well. Okay, so the urea, we saw a significant difference. Survivors had low level of urea compared with fatalities. Same with BAME group, survivors had low level of urea compared with fatality group. Sodium levels, so we looked at 2 different levels, less than 133 and greater than 146. We found, again, the survivors in Caucasian had a low level compared with the survival, and fatality group, the BAME group, again, had a lower level of sodium compared with the fatality. So high level of sodium was observed in both cases of Caucasian and fatalities, and BAME group fatalities. Albumin, that's where we saw another significant difference, less than 5. We saw, again, a significant difference between survivors and fatality in Caucasian and also in the BAME group as well. Creatinine, we did not see significant difference in the Caucasian group between survivors and the fatalities, but we saw a significant difference between survival and fatalities in the BAME group. We did not find any significant difference in ALP or ALT, the liver damage markers. Same with the bilirubin. CRP was the next parameter where we saw the significant difference. So for the Caucasian group, we saw the CRP was lower in the survival compared with the fatalities, and same with the BAME group, we saw the CRP was lower in the survival group compared with the fatalities. LDH, we found again a significant difference there. Survival group had a much lower value compared with the fatalities in Caucasian group, but we did not find any difference in the BAME group. So BAME group did not find any significant difference there at all. Troponin level, we found no difference at all between the survivors and fatalities of Caucasian, but we found significant difference in the survivors and fatalities of the BAME group. Next slide, please. So just summarizing table 3, the potassium creatinine levels in BAME group fatality was significantly higher compared with the Caucasian group. The urea to albumin ratio was significantly different across the groups, and the general linear model analysis adjusted for age observed the mortality and ethnicity interaction was significant for this ratio. LDH concentration in Caucasian survivors was significantly lower compared with both fatalities groups. And there was a significant interaction and effect of ethnicity on the mortality as well when looking at the LDH. Next slide, please. Now, looking at the forest plot, presenting the risk factors associated with the mortality. The plot A is of the Caucasian odds ratio, looking at multivariate logistics. So first of all, you can see diabetics has a little role to play. The neutrophil to lymphocyte ratio, yes, it's a bigger risk factor there. And then looking at the urea to albumin ratio, when it was greater than 0.2, it had a bigger role to play. If you compare that now with the lower graph, the forest plot, the BAME group, what we do see there is diabetes. Okay, diabetics has a big risk factor in the BAME group. And then the neutrophil to lymphocyte ratio, again, was another risk factor, but the biggest one we found was the urea to albumin ratio. That was a much bigger risk factor compared with the Caucasian group. Next slide, please. So, summarizing this, Caucasian neutrophil lymphocyte ratio and the higher urea albumin ratio and the higher ALT albumin values above 7.4, 0.28 and 238 respectively increase the odds of death. In the BAME group, being older than 60 of age, diabetic as well, as neutrophil lymphocyte ratio and urea ratio above 7.4 and 0.28 respectively increase the odds of death. Next slide, please. So summarizing it, so it will be useful for clinicians to use a neutrophil over lymphocyte ratio greater than 7.4 and the urea over albumin ratio greater than 0.2, ALP over times ALT over albumin ratio index greater than 238 specific to the Caucasian group as the indicator of severity, and consider appropriate interaction to reduce the mortality in COVID-19 patients. The BAME group or BAME subgroup, age greater than 60-year-old and those with diabetes are at a high risk of death. They should be appropriately protected, vaccinated, and intensely monitored should they present with COVID-19. Attention must be given to good health education about diabetic control in all ethnic groups, but so in the same for the BAME group as well. Next slide, please. Conclusion. So neutrophil to lymphocyte ratio and urea albumin ratio are simple matrix that can predict death to aid clinician in determining the prognosis of COVID-19 positive and help provide early intensive intervention to reduce mortality. In the BAME group, intensive monitoring at even a younger age, those with diabetics may also reduce COVID-19 associated mortality.